Thank you very much. You can look at the slides or you don't have to look at the slides. I'm just going to talk. It's something that we need to start thinking about. I sleep with many pharma and this is one of them, right? Let's take our patients. Here's a 49-year-old with a HbA1c of 9.5, glucose are high, right? And and the patient is on the usual culprits of medication and reluctant to take insulin, correct? Everyone knows what we should do. The patient actually requires either a GLP-1 RA or he requires a basal insulin. GLP-1 RA may be out of reach, but basal insulin may be something that he doesn't want. Right? Why do people not take care of insulin? The most important thing to remember is that many of the times we talk about we cut and paste all this information from Western literature, and our lived in experiences are very, very different. The most important thing is that physicians don't want to give that extra few minutes required to start insulin. It's as simple as that. Because our patients are not really, if you ask 100 patients, it's only one or two who will say that I'm scared of needles, right? The others don't want to be bothered because either they have a family experience of somebody who was started on insulin and then died because they were started too late, right? Or somebody has told them it is addicting. If I get on insulin, will I not be able to get on it? If I get on insulin, will I be addicted to insulin? The word addiction is very, very common in my practice. I'm sure, how many of you have heard the same thing? Will I get addicted to it? All of you have gotten it, right? Second, one of my family members developed kidney failure after this. These are the only two common things, nothing else, right? So, I'm not the IDF president, so I'm not going to talk about all of this. I don't want to talk about capital, care capital, all of these. But what is important is that we are as true as the rest of the world. Just can we cut this chatter down, please? I'm a little older and I have hyperacusis. सर आपसे ही बोल रहा हूँ थोड़ा बात कम कीजिए, right? So most people delay insulin for many reasons. Each time there is an excuse, but also let us understand that it is not just the patient's issue. It is our issue. The reason is many of us want to upgrade ourselves to be a diabetologist or a person taking care of patients with diabetes, but are not willing to provide the time that it takes to be a diabetologist. It requires those extra few minutes to the patient. I'll give you a very typical example. Forget all of these needle phobia, this phobia, that phobia. A patient comes to you, right? And you say, I want you to take insulin. And immediately, no, doctor, I don't think I want to do that. What do you say? You get very angry. मैं डॉक्टर हूं, मैं बोल रहा हूं, तुम क्यों नहीं ले रहे? You turn him away, he goes to the man the other side. All it requires is to say, okay, you don't want to take it now. But what I want you to do is, I want you to think about it. Or look, your family member is here. Why don't you talk about it and come back to me? You can go outside, sit and talk about it and come back to me. It's okay. I will give you what you want this time. But when you come back next time, if you have not achieved the results that you want, can we talk about this again? It's just our approach. Our approach to insulin has always been patriarchal. We got called patriarchal for all sorts of wrong reasons. But this is the patriarchal reason, right? That not respecting the patient's ability to think for themselves, giving them the time to reflect. When you say something, what happens when your wife tells you something? You immediately react. Then you regret it for the rest of your life. But if you what does your wife do? She keeps quiet when you say something, and afterwards you go and say sorry. Simple. Your wife never says sorry, you do. But it's a simple psychological thing that we forget, that people need time to reflect on choices. And if you respect them and say, look, I understand this, but can we discuss this again? At some point of time, it changes. I think that's all I want to talk about the psychological and other issues. But having said that, right, convenience is an important factor in how we take care of diabetes. That that patients require solutions that are long lasting, solutions that will allow them not to be tied to a syringe, not to be tied to their meal requirements, to have a fill it, forget it, shut it parameter. So clearly, but those of you, I mean, I have lost as much hair in the last 2 decades and it's grayed all over that I don't even try to hide it. I never tried to hide it, but I don't try to hide it anymore. But it's very interesting to understand how insulin has evolved, right? When we first started, for those of who are younger, you don't remember the kind of travails insulin used to have. So when the first basal, long-acting basal insulin came, it became very easy because patients no longer came and banged at you and said, I want to get off the insulin, right? People were afraid to give insulin simply because the insulins that were there in that part of time had problems because they were not long-acting enough. What is the problem with not having long-acting? The tail wags the dog. It's not the dog that wags the tail, it's the tail that wags the dog. When the effect of insulin keeps coming down, at the tail end there is a wide swing of glucoses. That excursions, even if it didn't cause hyperglycemia, would cause symptoms of ups and downs. That changed. Then you started getting insulins that are fairly long acting. And that has made a huge difference. You don't have, when you start somebody on a basal insulin today, you don't have patients who've come and say, I want you to get me off this. Correct? They don't do that anymore. But I have these patients who come and say, sir, idora better meaning, is there anything better than this? There are a bunch of patients who now know who have that things improve. And really that part that these innovations are taking, right? That patients come and say, look, I'm happy with the basal insulin I have, but if you have something better, I would like that. And that's really all that is, that patients also look for evolutions in your care. So doctor, 5 years ago, this was like this, 10 years ago, like this, 20 years ago, like this. And what does it do? If you look at the history of patients with diabetes, you'll realize that your patients' glucoses are actually not as great as they would be. Why? Because they are humans like you. You would have a diet, but yesterday evening you would have eaten whatever you wanted. Simply because Banshi is served a platter. Similarly, patients would feel, on the day that you do exercise, you feel like eating more. Similarly, people will say, today I'm traveling, I don't need the insulin. Today, you know what, I've come home very late, I'm tired, let me not take it. So patients actually miss at least 1 to 2 doses, if not more, of insulin per week. And that actually impacts their level of care. It does impact their level of care. So clearly, if you were to have a way to reduce the insulin frequency, that makes a difference from 3 to 4. Why do you think that Rhizodec twice a day is better than basal bolus insulin? Simply because it reduces the number of insulins required. Similarly, if you do once a week insulin, it makes life easy. It also reduces, despite in Tamil Nadu, there's a big problem. When the educators teach, they tell you, take it around the umbilicus. Guess what our patients do? They actually do it just here. And you get these hypertrophies. I find that now I do it. I say, do this, and this, and this, and this. Otherwise, they say, sir, can you take it in the thigh? No, do this. But clearly, these factors are all of that. So the simplest way to take care of patients is one, and now we have information with weekly injections, with semaglutide, with dulaglutide, all of that. We realize having once a week is actually a good way. On Sunday morning, I get up, before I have my breakfast, I have both my doses. And that's really, I think, what people are going to talk about. It's a preview for once a week insulin. But I hope I made a case that medicine is not revolution, it's evolution. We started with pigs and dogs. We went to humans. We went to short-acting insulins. But I think besides the GLP-1 RAs and SGLT2 inhibitors, the greatest innovation we've had is a long-acting insulin, because long-acting insulins are safe, they're effective, they're convenient, and along with a pen and smaller needles, they work very, very well. I will stop here.